The perspective of my talk actually comes from an AUA course. So the AUA has a committee on laparoscopic and robotic new technology, and the committee does various projects for our organization, and it's under the Office of Education, so it ultimately reports up to Vic Nitti, and his group separately has to decide like which courses get taught at the AUA. So a question from 2 years ago is, should the AUA be teaching focal therapy, or how should they be teaching it? And there's a lot of debate about that. And what we came up with as a committee was the data wasn't really ready to do like a hands-on, let's go prime time with focal therapy, but we didn't want to ignore it. So what we came up with more of as an informational type of course on what are the required elements, what are the challenges moving forward. So I put forth the course, application process and put faculty from the committee on there. And my role in the course was to be sort of the skeptical voice of reason, if you will. So these are some highlights from that as a way to I'm not going to take down focal therapy. I'm just going to kind of show you kind of the issues on it. Obviously, focal therapy is targeted focal destruction of cancer tissue with preservation of surrounding healthy parenchyma, according to one definition. The nomenclature is likely more in line with index lesion ablation rather than subtotal ablation, although a lot of the older data is more of subtotal ablation. So what John Ward did at our place was what he calls hockey stick, and there's good radical prostatectomy data on that, where if you really want to eliminate most of the tumors, if not all of it, in unilateral biopsy. Remember, his protocol was pre-MRI, so it's just like if you came in with one core of 6, you could do unilateral cryo, and then he would have to hit the whole anterior contralateral side to sort of have a real cancer-looking apparition to it if you were comparing it to radical specimens. Obviously, as Jeff mentioned, lots of endpoints you can argue about, and I'll show you a few of those. And then there's the results of radical prostatectomy in people who would be candidates for these. A big question is accuracy of imaging and what happens with significant versus insignificant disease. What are we gaining, as he alluded to. Now, the pro of all this is obviously this seems more personal and adaptable to the disease and the patient. A lot of proponents that give your talk like to, do the hammer, crushing a fly or whatever for all prostate cancer. Does it hit a sweet spot between active surveillance and intervention? Better quality of life, absolutely, and so is active surveillance, by the way, and so that's the other comparison, more than RP in my opinion. Does it simplify natural history? A lot of people on surveillance are satisfied, but they're like, is that all we do? Do we just sit here and wait for something to happen other than you tell me I can't have red meat anymore? I mean, what are we actually doing proactively, rather than just wait on upgrading? And what are the lessons from randomized trials on that I'll move over? On the con, MRI definitely has limitations. In Houston, as most of you know, we don't have any zoning restrictions, so you can just build stuff all over the place. And we were at some restaurant, and there's this great, those strip mall signs with all the businesses, and there's like a nail salon, a hair salon, gardening something, and then precision MRI, mixed with all those random businesses, which I took a picture of that, but it made me laugh because, MRI, the prostate currently is not precision. It's kind of estimation. We'd like it to be precision, but that's the rate limiting part. Margin of error, if you're really going to do lesion-directed therapy, what's the margin of error you have to put around that, and how are you going to deliver that? What about the multifocal issue? Also remember that if you really study all your RP specimens, the highest grade tumor is not always the biggest one. Sometimes it's the second biggest. Not very common to be third or lower, but the point is it's not always the biggest one that you're seeing. So MRI might be misleading you about what to treat in the first place. And is monitoring actually any better? If you have active surveillance, like we've done in the previous talks, you're going to get repeat biopsies. You might get genomic tests. You get PSA trending. If you do focal therapy, it's the same thing. You're going to get imaging. You might get genomic tests. You get PSA trending. Your PSA does not go to 0. It has to be interpreted somehow. So, what are the aggregate costs of that version? Is salvage actually straightforward? It depends on what you did. So as many of you know, there's a big laser center down in Galveston, and I've salvaged a few of those. And it turns out it's not a problem. So that's kind of takes the winds out of my sails on that argument. But, it's clearly different than brachy or, legitimate whole gland organ. Most series, as Jeff conceded up front, 20 to 25% are going to have cancer at 12 months post-therapy. According to AUA guidelines, this is not frontline therapy. It should be done on a research or some sort of registry protocol. This last bullet point was something that it was a good journal urology debate. Priester is a first author for basically the UCLA imaging group, and they estimated with one technique that 80% of tumor volume is outside of the ROI boundaries drawn by most MRIs. That's a big number. Now, if you then follow the letters to the editor, one of which was written by Mark Emerton's group, they kind of showed how if you modify X, Y, and this gets out of my wheelhouse, he says it probably should be under 10%. It's not zero, but so there's still some debate about, again, does MRI even take you to the right place you're supposed to be? So here's some just statements to kind of go with for now for advice. If you really want it to be a cancer operation, actually the hockey stick data is probably better than lesion directed until we get a little better at the issues noted. Jim Hugh actually put a separate paper in Journal Urology on just how to do, what are the construct elements of a clinical trial registry. And we say trial and registry, that doesn't mean it has to be academic, private groups that funnel cases to experts can participate in these type of activities. Most people say the ideal selection is the intermediate, preferably the favorable intermediate range. And part of that's because there's no way you're going to prove anything oncologic in Gleason 6 anytime soon. And once you get to 4+3, hence remember my slide 1 from the other talk, look how many of those are outside of the prostate to begin with. If you start tempting yourself in 4-3, unless you really pick the right people, you might be playing with fire. So I think the AUA wants us all to be fair on the topic, not encouraging, it's like our course was not meant to be a marketing how to do it, but not being dismissive about it either. It's clearly not going anywhere, I would say. So intermediate risk volume, by the way, is the most commonly diagnosed prostate cancer. It's more than Gleason 6 or 8, and by ratio alone, it drives more failures than the others just because of the numbers. There are about 80 focal therapy trials on clinicaltrials.gov, and overall 2,700 treated according to one source. Are there, and it's kind of interesting, are there excessive barriers? I mean, some of the underlying themes of Mike Davis's talk is that, robotic surgery got, rolled out with no barriers other than, can you convince your hospital administrator to buy one? Now we're putting pretty extensive levels of evidence on focal therapy, and look what HIFU had to do even to get their basic FDA clearance. Fair or unfair, who knows? It is fundamentally different. I mean, I would say robotic prostatectomy, you get a path report, is different than biologically than what you're doing focally. So lots of other emerging ideas, MRI thermal monitoring, vascular immune approaching. I find it interesting that the Lepore, and similar to the technique done in Galveston, they use like a robotic Artemis biopsy tool to select the patients and do the diagnosis. And then when they do the treatment, it's freehand, this interstitial laser. So there's probably some inaccuracies there. So now then the thing that always gets asked, and there's a lot of ways to phrase it, is, are we supposed to jump on this train? Nobody wants to get left behind. And I just would caution you, if you're going to get on a train, be sure it's a high-speed Japanese rail, always on time, always safe, lots of good food, and just be sure it's not, a train going off a cliff. So also ablation methods, remember that there's really very few comparative data on actually which of these to do. So you might use cryo or HIFU just because you have the machine and know how to do it. Then there's all sorts of others. Actually, the brachytherapists are kind of getting slowly interested in that. And if you got a great brachytherapist, all right, we'll just seed this part of the prostate if you want them to. And again, status of active surveillance. There are downsides. Anxiety, repeat biopsies, testing cost is noted. Whenever you construct active surveillance, it's almost the same question as focal therapy. Who are you going to include? How do you monitor them? And how do you declare success and failure? Back to the HAMD UK PROTECT trial, a lot of the actively monitored patients, 50% got treated on that trial. Of course, they weren't super selected up front with all the techniques we've talked about today, so I'll skip that part. And also, I think your benchmark matters. So this was a slide Manny Menon put up right when PROTECT came out. In the open surgery arm of PROTECT, 26% incontinence at 1 year. in Detroit, with the the Vatucci technique, they say 1 year incontinence rate 3.7 with a similarly worded definition. The active surveillance of Protect had higher incontinence rate than the treated patients in Detroit, if that makes any sense. So maybe you just have to do your own comparisons to counsel your patients. So the Yaxley study, for example, that who did Yaxley? Mike did Yaxley study. Yaxley, by the way, is an incredible open surgeon, and now that he's finished his trial, he does all robots, by the way. And the robotic surgeon there is one of Vip Patel's trainee, Jeff Coughlin. Very good surgeons in that. But the nice thing about that trial is that they use EPIC standardized reporting surveys. So and that's what we use. So you can go line for line and look at the results. The first paper had 3 months. Now I think they just put out 6 months data. You can show a lot of similarities in, what was the quality of that surgery. It turns out it's very similar to ours. Therefore, I'm going to say it's very high, right? So you can get into that nuance. So these are kind of like our EPIC urinary functions. So obviously, EPIC urinary function drops off and then recovers. This gold line is brachytherapy. That's all driven by irritation, not continence. And then a lot of similarities. If you were to compare EPIC sexual function, actually the lowest line, that's not surgery. Surgery is in blue. Yes, we go down and improve. The lowest line in our experience is IMRT with 6 months of ADT. So everyone says IMRT is great on potency, but not if you give 6 months ADT. In the second year, maybe that could be different. So be clear about what you're comparing. So I probably don't have time for the full case report, but remember I was supposed to be the skeptic for the AUA course, so I showed some examples of people with clearly not good disease. Here's a tumor map of actually one of my patients that went out of state to get focal therapy, and he had a very suspicious T3 looking MRI. Bottom line is he was metastatic progression within 2 years. It also made me think, you ever have, people in the lay press love saying like, oh, you should get a second opinion, right? I mean, that's like a throwaway advice. Yes, get a second opinion. Well, this guy got like 9 opinions. And I think I was the 7th opinion. And when you're in the 7th opinion, after a while, you're not really clear if you're involved in this case at all beyond the day you saw the person. So there are some people, and that's what you got to be cautious about. There are people seeking these type ideas who are struggling with the standards, and sometimes they can undo themselves by overthinking this. And when I talked to the people who treated, they were like, well, we told him he wasn't a good candidate, but he went on the protocol anyway. I'm like, well, why didn't you just say no? So there's some discipline involved here. So I'll skip all the images, but it was a rip-roaring case. Now I've seen another one just like it that was bad. I've also seen some that just recurred a little bit, and maybe they got radiation. So it's all over the map about who got salvaged. And again, I've done a few of the laser salvages that are still just contain 3/4s, and maybe that's not so bad. So I'll skip all that and get to, there are some nice, with the, oh God, what's the consensus reporting method? Basically, I'm having a moment. When there's no data, one way to get data is to get 15 fairly non-randomized or non-randomly selected experts together and tape record everybody talking about it, and then go back later and say, well, we agreed on this, and we didn't agree on that. The Delphi method. There we go. So, there's really not even a systematic review on this topic. At best, there's a Delphi method, which is just experts saying what they believe while they're having coffee. So these are the things they agreed upon. It's mostly what we mentioned about 3+4 type disease. PSA under 10, almost like treating any other treatment candidate. But then there's a big table on what they don't agree on, and so that needs to be worked out as well. So conclusions, room for focal therapy, yes. Gleason 6, good luck proving anything. I would probably stick with surveillance for now, but that's just me. And maybe a high volume Gleason 6, you could draw some distinctions in there, here and there. Remember, if someone has separate paper, if someone has like 6 cores of Gleason 6, and you can see it on MRI, they will be upgraded at surgery for sure. So maybe you just, in your mind, say, okay, that's actually a 3+4, I just haven't proven it yet. But proven 3+4 for sure. Above that, depends on if you like playing with fire. Quality of life is definitely better, but I would say, and I didn't really get into all the weeds on that, the differences in urinary outcomes in expert hands, very small, arguably not a big deal for the patient. ED is a big deal. It will be substantially better on focal therapies. So that's your trade-off at times. So, all right, thank you.